Morning, dear students. Today we are discussing about management of deep caries lesions. These are the contents you need to include: indirect pulp capping, stepwise excavation, direct pulp capping, ideal requirements of a pulp capping agent, materials used for pulp capping. Starting with the introduction, once the pulp gets exposed, the aim of the treatment is to promote pulp tissue healing and preserve pulp vitality. Vital pulp therapy procedures involve removal of irritants of the pulp and placement of a protective material directly or indirectly over the pulp, followed by a tight seal restoration. And this is performed to treat reversible pulpal injury to promote root formation and apical closure. Definition of indirect pulp capping. It is defined as a procedure wherein the deepest layer of remaining firm carious dentin is covered with a layer of biocompatible material in order to prevent pulpal exposure and further trauma to the pulp. This is the diagrammatic representation. You can see the internal restorative material at the top. Just below that, calcium hydroxide liner, and below that you can see the deepest layer of carious dentin, which is in close approximation with the pulp. And the objectives of indirect pulp capping include arresting the carious process, promoting dentin sclerosis, stimulating formation of tertiary dentin, and remineralization of carious dentin. The rationale behind IPC: carious dentin consists of two distinct layers, infected dentin and affected dentin. Infected dentin is an outer layer that is irreversibly denatured, infected, not remineralizable, and should be removed. On the other hand, affected dentin is an inner layer that is reversibly denatured, not infected, remineralizable, and should be preserved. Removing the outer layers of the carious dentin that contain the majority of microorganisms, thus reducing the continued demineralization of deeper dentin layers from bacterial toxins, sealing the lesion to allow the pulp to regenerate reparative dentin. Calcium hydroxide, being alkaline in nature, can eliminate virtually all the remaining bacteria and render the residual carious dentin sterile. Placement of a well-sealed interim restoration, such as reinforced DIC or zinc oxide eugenol over the calcium hydroxide liner, will deny the remaining bacteria nutrients for further acid production and thus arrest the carious lesion. Coming to the indications, they can be classified in three ways, that is, history, clinical examination, and radiographic examination. The patient should have a negative history of spontaneous extreme pain, and on clinical examination, deep carious lesion which are close to but not involving the pulp in vital primary or young permanent teeth. There should not be any mobility, and when pulp inflammation is seen as nominal and there is a definite layer of affected dentin after removal of infected dentin. Radiographic examination, there should be normal lamina dura and periodontal ligament space, no radiolucency in the bone around the apices of the roots or in the percussion. Similarly, contraindications include, in case of history, sharp penetrating pulpalgia indicating acute pulpal inflammation and prolonged spontaneous pain, particularly at night. Clinical examination, mobility of the tooth, discoloration of tooth, and negative reaction of electric pulp testing. And on radiographic examination, definite pulp exposure, interrupted or break in lamina dura, radiolucency about the apices of roots, and widened periodontal ligament space. Moving on to the treatment procedure, local anesthesia is administered and the tooth is isolated with a rubber dam. Remove all undermined enamel using high-speed handpiece with air water spray. Excavate the soft carious dentin and take care to retain the deepest layer of carious dentin close to the pulp. Then apply a liner of calcium hydroxide over this deepest layer of demineralized dentin. Finally, place a well-sealed interim restoration of reinforced glass ionomer or reinforced zinc oxide eugenol over the calcium hydroxide liner. A permanent restoration may be placed after 6 to 8 weeks after evaluating the patient's response. Between the appointments, tooth must be asymptomatic and temporary restoration must be intact, and if a reparative dentin bridge is formed, a permanent restoration is placed. Then procedure of application of pulp capping agent. The most frequently used one is dical or calcium hydroxide, which is supplied as a two-phase system consisting of a base paste which is brown in color consisting of titanium dioxide and glycol salicylate, and catalyst paste which is white in color consisting of calcium hydroxide and zinc oxide in ethyl toluene sulfonamide. One drop of each paste is dispensed in the mixing bag. Now the catalyst paste is lifted with a blunt probe and carried to the cavity where it is spread all over the cavity floor only. In similar fashion, the base paste is taken to the cavity and the two pastes are then mixed in the cavity and spread evenly with the help of a ball burnisher. This evenly mixes the paste and also allows a uniform thickness to be attained in the cavity. Although dical can also be mixed on the pad and carried to the cavity, the other method is more convenient as dical sets very fast after mixing. And the prognosis, the success is good in young patients due to the presence of a large volume of pulp tissue and good vascularity. However, in older patients, the prognosis is not so good as the pulp may show degenerative changes. Coming to stepwise excavation or serial excavation or gradual caries excavation, it's a two-step excavation procedure advocated by Magnuson and Sandel and then modified by John Dahl. Case selection criteria are the same as for indirect pulp capping procedure. In the first visit, access is gained to the carious lesion. Superficial infected dentin at the periphery is removed, leaving behind the soft infected dentin at the deeper portions, and this is followed by placement of a calcium hydroxide liner on the dentin and a glass ionomer temporary restoration. In the second visit, after 3 to 6 months, in the absence of symptoms, re-entry to the deeper portions of the cavity is achieved and remaining caries is excavated, and the caries will be darker in color, harder and drier in consistency. Pulp protection is achieved by placing calcium hydroxide covered with a glass ionomer liner, and finally a definitive restoration may be placed. And the rationale of stepwise excavation, progression of caries is dependent on continuous supply of substrate, and if supply of sugar substrate is stopped, bacteria are no longer able to metabolize and their number reduces and activity of the lesion slows down. So in this method, caries lesion is sealed from oral cavity using hard restorative material. Following sealing, the caries dentin becomes dry, harder and darker in color. As a result, there is shrinkage of the tissue, leaving a void beneath the restoration. The final excavation is done because it is more convenient to excavate the harder, darker caries than the soft, yellow, demineralized dentin. Sealing the infected dentin from the mouth allows the pulp dentin complex to lay reparative dentin. And the indications include deep caries lesion, no history of spontaneous pulpal pain, no radiographic evidence of periapical lesion, and positive response to pulp vitality tests. Now, two-step excavation approach is recommended because it avoids unintentional pulp exposure, gives opportunity to remove slow progressive lesion in slightly infected, discolored and demineralized dentin before placing final restoration, and the dentist also gets time to evaluate the tooth and caries activity, and in second setting it becomes easier to remove the dry carious dentin. Now, direct pulp capping, it is defined as a procedure in which the exposed vital pulp is covered with a protective dressing or base placed directly over the site of exposure in an attempt to preserve pulpal vitality. As you can see, calcium hydroxide liner is placed directly over the exposed pulp, followed by a restorative material. The objectives of direct pulp capping are to create new dentin in the area of exposure and subsequent healing of the pulp. Rationally, to achieve a biologic closure of the exposure site by deposition of hard tissue barrier, that is dentin bridge, between the pulp tissue and capping material, thus walling of the exposure site. And indications include small mechanical exposure surrounded by sound dentin in asymptomatic vital primary teeth or young permanent teeth. Exposure should have bright red hemorrhage that is easily controlled by dry cotton pellet with minimal pressure. And there should be a true pinpoint exposure which is less than 0.5 millimeter in diameter. Contraindications include severe toothache at night, spontaneous pain, tooth mobility, radiographic appearance of pulp, periradicular degeneration. Excess of hemorrhage at the time of exposure, serous exudate from the exposure, external or internal root resorption, and swelling or fistula. And treatment considerations: first, debridement. Necrotic and infected dentin chips have to be removed, else they will invariably be pushed into the exposed pulp during last stages of caries removal, which can impede healing and increase the pulpal inflammation. Hemorrhage and clotting. A blood clot should not be allowed to form at the exposure site as it may impede pulpal healing or formation of proliferative dentin. And bacterial contamination, once all the caries or debris is removed, the cavity should be irrigated with saline, and if not, the debris may interfere with healing. And the technique of direct pulp capping, first, rubber dam should be placed as it provides only means of working in a sterile environment, so it has to be used. And once an exposure is encountered, further manipulation of pulp is avoided. Cavity should be irrigated with saline, chloramine tea, or distilled water. Hemorrhage is arrested with light pressure from sterile cotton pellets. Place the pulp capping material on the exposed pulp with application of minimal pressure so as to avoid forcing the material into pulp chamber. Then place a temporary restoration, and after 6 to 8 weeks, final restoration is done after determining the success of pulp capping, which is done by determination of dentinal bridge formation, maintenance of pulp vitality, lack of pain, and minimal inflammatory response. Now, prognosis, direct pulp capping is successful mostly in young patients with a pinpoint pulp exposure that occurs during cavity preparation, provided the capping is done immediately without any contamination. However, long-standing exposures due to caries have a poor prognosis. The ideal requirements of a pulp capping agent include it should maintain pulp vitality, it should stimulate reparative dentin formation, it should be either bactericidal or bacteriostatic in nature, be able to provide bacterial seal, it should adhere well to both the dentin and the overlying restorative material, be able to resist the forces under the restoration during the lifetime of restoration, it should be sterile and be preferably radio opaque. And the materials used for pulp capping include calcium hydroxide, mineral trioxide aggregate, zinc oxide eugenol, tricalcium phosphate, tetracalcium phosphate, calcitonin, dentin bonding agents, growth factors, resin modified GIC, intermediate restorative material, and dentin shavings. However, the most commonly used materials include calcium hydroxide, MTA, and calcium silicate based cements. Conclusion: the main aim of management of deep caries is to inactivate or arrest the lesion by changing cariogenic environment, placing pulp protective or therapeutic agent, and hence enhancing the defense mechanisms of the dentin pulp complex. Thank you.